science policy briefs. Just going to give a little intro to TSPN and who we are before we get started. You guys go to the next slide. All right. So just a little outline of what we're going to be doing today. We'll start off with a little introduction about what TSPN is. And then I'm going to hand it off to Luna to introduce our speaker for today. Afterwards, we'll have, our speaker will give an introduction to policy briefs, and we'll also go through a case study, and then we're going to have opportunities for audience questions as well. You guys can go to the next slide. So just to go over a few housekeeping items, we just ask that if you're on Zoom, you stay muted during the presentation so there's some background noise. And you can write your questions in the chat during the Q&A periods. You can also view live captions with the controls indicated there. Next slide. So before each of our events, we like to acknowledge that the history of the land on which we're living. Canada's home to many different Indigenous peoples, and we ask that each of you take a moment to learn about and reflect upon the Indigenous peoples on whose lands we are currently working and living. And you can find out more about that at the link on the slide. And also just another housekeeping item that we are dedicated to providing a harassment-free event experience for everyone, and that we don't tolerate harassment of any kind from event participants in any form. And if anyone is violating those rules, they may be asked to leave the event. Next slide. So to give a little introduction to who we are, the Toronto Science Policy Network. We are a student-run group at UofT, and our goal is to provide a place for students and postdocs and anyone in the UofT community to learn about science policy and engage in science policy. And we have advocated for evidence-based policies, and we also run events like this one, which are about educational opportunities and teaching our community about science policies through things like workshops, talks, panels, and campaigns. Next slide. So to give this little introduction to kind of what is science policy, we like to ask these three questions to our audience to think about. So what is science policy? Where does science policy fit in with other forms of science translation? And where do you fit into this space? Next slide. So there are a lot of different ways that scientific research can be implemented in many forms. Go ahead. As you can see here, we've listed a lot of them on this slide. And the three kind of main branches here are that scientific research can be communicated to the scientific community, to the public, or to policymakers. When you think about science communication to the scientific community, we think about things like publications and presentations at conferences, and also science education for, say, like graduate students. Science can also be used to provide information to the public in the form of science journalism, science outreach, and science education, as well as in the form of products and services like new technologies and product development. And then where science policy kind of fits into all this is when scientific research is communicated to policymakers for the purposes of making policy. Go on. And this can kind of be broken down into two forms, which are science advice and science advocacy. Science advice is really when the policymakers are employing or seeking out advice from people who are knowledgeable about the science that's relevant to the policies that they're making. And science advocacy, which was the subject of our first installment of this workshop this year, is really about the public and along with people who are knowledgeable about science, advocating for policies that the science is supporting. Go on. And so this is the branch that we like to call science for policy. But importantly, all of those pathways can kind of loop back and influence what kind of scientific research is conducted next. So the type of, the scientific quality of knowledge can kind of influence what research scientists want to do next. The knowledge of what the public is interested in can influence what science is done next. The types of technologies that are available can really influence what kind of science can be done. And policies that are in place can really decide how much funding goes towards science and who is able to conduct science. Next slide. And so as I mentioned, these pathways from scientific research to policy have been the focus of our workshop. And the first workshop, we talked about science policy advocacy. And in this workshop, we're going to be talking about writing policy briefs, which is something that people that give science advice have to do a lot. And so to give a little introduction to our speaker for today, we have Luna from TSPN Exec.
Hi everyone, so I'm honored to be introducing our guest speaker for today, Charissa Levy. So Charissa Levy is an executive director of the Rehab Care Alliance and GTA Rehab Network. She's an occupational therapist and has held clinical and leadership positions in healthcare for over 20 years. Charissa provides strategic and operational leadership to identify issues and implement collaborative, evidence-based approaches that drive improved health services. She has been invited to participate on a variety of provincial and regional expert panels / committees to inform policy directions and clinical service planning. She also has served as a key informant to Auditor General of Ontario's review of rehabilitative hospitals in 2013. Charissa received 2016 UofT Society of Graduates Literacy Award in Health Services, Policy and Management for her paper Realizing the Potential of Rehabilitative Care for People with Complex Health Conditions. The time is now. Charissa is also an adjunct lecturer in the Institute of Health Policy, Management and Evaluation at the University of Toronto. So please join me in welcoming Charissa Levy for today's speaker.
Thanks, Luna, for that wonderful introduction for Charissa, and not me. I think I'll do a quick intro of myself. My name is Maria Medalanu. I'm a PhD student and also co-president of the Toronto Science Policy Network. And I'm just going to give us a little brief kind of rundown of what a policy brief is before our guest speaker is going to walk us through some more in-depth slides as well as some interactive workshop components. So today I'm showing a training tool developed by the IDRC, that's the International Development Research Centre, a Canadian organization supporting research in developing countries to promote growth, reduce poverty, and drive other large-scale positive change. And IDRC is a really crucial, as well, a really crucial training body that provides a lot of different resources in making sure that the research that is done is translated and just basically good knowledge translation practices. So I think this is a really nice deck that we're going to leverage today. Next slide, please. So first off, what is a policy brief? We're going to just go one more slide. That's great. So it's really a key tool to present research and recommendations to a non-specialized audience. And this is really, really key because you want to be using clear and concise standalone, clear and concise language. And you also want to make sure that this policy brief is standalone, that really focuses on a particular topic and that distills research findings in plain language, drawing clear links to policy initiatives. Next slide, please. So for today, we're going to talk about planning your brief. We're going to go through what a template of a usual brief looks like, how to design your own brief, ideas of revising your brief, and how to really leverage the brief. Next slide, please. So first, planning your brief. You want to think about what the purpose of your brief is, what's your target audience, what type of content and structure are really vital elements for an effective brief in your scientific area. Next slide, please. The purpose of a brief is really to inform readers of a particular issue, suggest possible policy options, and make recommendations. And you really want to be upfront with your purpose from the start, because that's going to gain the attention of your readers. And you want to maintain a laser focus on your direction and communicate the real urgency of the issue. This is really important because policymakers are very busy people. They have a lot of meetings. They're met with an enormous amount of information, and they meet many different people every single day. So you want to make sure that you're very clear in what your purpose is, and that you're really focusing on the benefits and advantages of following your policy advice or following the science that you're trying to convey. Next slide, please. And really, you want to make sure that your brief is accessible to your target specific audience. And you want to think about who your prospective readers are, what level of government, for example, what level of stakeholder engagement they already have experience in. And you want to think about what their interest and level of knowledge of the subject is already, as well as level of information that they require to make a good decision. And on top of that, you're always you also want to be aware of the openness that they might already have or not have to your recommendations. Next slide, please. And the content of a brief should really be brief, maximum 150,000 words or 2 pages in length. And you want to avoid tangential information or being overly descriptive about methodology for describing your study or a group of studies for a body of research that's already been done. And you really want to draft a new purpose-driven policy instead of summarizing or cutting down an existing report. Next slide, please. And the structure should really lead the reader from the problem to the solution. You want to be clear about your recommendations and how they are supported by the evidence. And this should really be audience specific and reflect each audience's interest, as well as what they can do with the information that you're providing. If you don't want it really to be kind of similar to a literature review or a long governmental report, you want to make sure that it's has a clear structure with clear aim, clear level of evidence supporting the recommendations. And some typical sections for the structure of a brief include a summary, as well as context, a section with analysis and discussion, and then finally consideration. So you're weighing the evidence, and finally making a conclusion or a recommendation. Next slide, please. But there really is no one size fits all approach, because there are differences in topics as well as differences in your audience that will really shape each one. So many policy briefs do tend to contain the same elements. Next slide, please. These are, as we mentioned, the executive summary, an introduction, the overview of the research or problem, examination of the findings, and that last section about the policy recommendations and implications of the research or science you are briefing on. Next slide, please. One more. That's great. Okay, so the executive summary. Every policy brief should open with a short summary, and this can be a few bullet points or a short paragraph or two. And regardless of the style, you really want to condense the essence into a few sentences. And this is really important that you're capturing the reader's attention. You're making it very clear where this is going. And ideally, an executive summary should be able to be standalone. So it should have a pretty good level of detail and depth and nuance that even if someone were not to read the next 2 pages, they would still be able to walk away with a good feel for where the policy brief would be going. Next, please. So some tips is that the summary should appear either on the cover of the brief or the top of the page, and it can be helpful to write the executive summary last. And this is really because once you've really written the brief, you have a lot of clarity on the content as you draft the other sections, and you know exactly what are the essential elements that need to be at the top. The only thing is, if they were to only read one thing, it would all be captured there. Next slide, please. And the introduction should really complement what you've written already in the executive summary, and you should set up the rest of the document and clearly convey your argument with the goal of really leaving readers with a clear sense of what your research is about while enticing them to continue reading. So you just want to be setting up the stage, kind of similar to an introduction you would write for a research paper or a research article. You want to provide background, but not really entirely give an entire scope of the field. It still should be pretty focused and pretty deliberate. Next slide, please. I think we can skip this tip to the next one. Great. The next thing is the research overview. And this is one of the really important sections because it's really explaining the reasoning behind your policy recommendations. So this is, in effect, describing the problem that your policy recommendations intend to solve. Next slide, please. And in the research overview section, you're going to want to give a summary of the facts, the issues, context, research methods, with a focus on 2 main elements. First is the research approach. So how the study was conducted, who conducted it, how the data was collected, and other relevant background information. But the key is relevant. So this is, again, not a specialized audience. It should really be on a kind of need-to-know basis. The level of information you think a reasonable person or a reasonable decision maker with their background. Sometimes you can find pretty good information online about someone's background, if they have scientific training, if they don't, if they have interest in an area, if they've never heard of it before, to kind of help guide what a reasonable level of research detail is needed, as well as the results. So painting a general picture of the results findings before moving on to the specific recommendations. Next slide, please. And you really want to avoid that jargon, avoid overly technical language, and focus on highlighting the benefits and opportunities stemming from the research. So really being solutions-minded, solutions-focused, and thinking about what can be done, leveraging that work. Great. And next is the discussion and analysis of the research findings. And this should really be bringing things together to help the reader interpret the data in a way that's accessible and clearly connected to your policy advice. The goal is to be convincing, but ensure that your analysis is balanced and defensible. Okay. Some tips are to express ideas using active language and strong assertions. Explain the findings and limitations of the research. It's really important to still, although you're making a recommendation or you're trying to brief on a certain policy that you might personally believe would be beneficial, you want to make sure that you do come across as balanced and that you're providing any kind of limitations or other kind of considerations that a policymaker should be made aware of when also interpreting this research or this body of science. Okay, next slide, please. And finally, the conclusion or recommendation. In this final section should really detail the actions recommended by the research findings. So you want to really draw that link for your readers. You want to use some persuasive language and present the recommendations. But again, you have to make sure that those arguments are rooted in research or science that you've used in your analysis sections, your introduction. So all building towards this kind of conclusion or recommendation. And ideally, you really want your reader to be convinced that yours is the best advice. Again, make sure that there's nuance mixed in there. Okay, so you want to both examine the implications and the recommendations produced by the research. So the implications are the effects that the research could have in the future, and follow up the implications with your recommendations. So beyond being descriptive, you want to make sure that you have a call to action by stating precise, relevant, credible, and feasible next steps. Okay, great. I think we'll skip this tip. I think we'll go a couple more forward to, actually back to sidebars. That's great. This is just a little tip. So it's really nice to add visual interest whenever you can. And sidebars are a great opportunity to add greater depth to a discussion and hook readers' attention without having like a really long number of paragraphs that are going in great detail. That sometimes having it broken up with a little text box is really nice, and making sure that it's short, engaging, and action-oriented is really great. So I'm going to skip again to the next slide, to graphics. Another thing, really choosing effective visuals for the information that you would like to communicate. These are, again, great to break up a lot of thick text. Next slide, please. So when you have your brief and you're revising it, you want to reflect again on your purpose, your audience, your content and structure, and you want to test it. So try to explain it in 20 seconds to assess which information stands out, what's really important, what's really central. Make sure, is it user-friendly? Have you removed the jargon and statistics and made it as approachable as possible? And finally, ask a colleague or friend or family member with no prior knowledge of the issue to read the brief and provide feedback. A good rule of thumb I've heard in my policy courses, if grandma and grandpa don't understand, there's too much jargon. Oh, great. So finally, using your policy brief, we're definitely going to talk about more of this in the next part of the talk, but a good brief can really play double duty by standing on its own or as an effective accompaniment to a presentation. So if you have a meeting with a policymaker, having that brief ready, either sending it ahead of time as a pre-read or a little pamphlet for after, is really nice to make sure that you're leaving something that's tangible for that policymaker to refer to or to share with others. And you want to make sure that you're tailoring your visual presentation by focusing on those key points and important questions rather than repeating all the brief's text in your presentation. Okay, great. So that wraps up our little introduction, our little rapid fire introduction, and I'm going to welcome Charissa to take it away. Thank you so much.
Thank you so much. I wanted to start off by thanking the organizers for having me. Really appreciate it. And I'm very honored that all of you took the time to join us today, especially when it's such a gorgeous day outside. And thank you to everybody joining in Zoom. And so we can go to the next slide. And just, I know you've already done a land acknowledgement, but wanted to give thanks to the beautiful land that we have and all of the work that we do. Recognize that we're working on behalf of those of Indigenous heritage who are the original caretakers, and recognize that they continues to be negatively impacted by Canada's colonial history. So moving on to the objectives, thank you. I just wanted to start off by giving a brief overview of rehabilitation. So that's sort of the space that I work in, and not everyone is familiar with rehabilitation and the organizations that I work for. A high-level overview of the health policy context, and I think some of that was actually just covered in the introduction. So I'll skip over where there's duplication, but I think there's some also different nuances as well. And then summarize key aspects of writing briefing notes. And again, where it's similar, we'll skip over, but there may be some differences there. I have two case examples from my work, and then we also have an exercise. So thank you to Luna for helping me pull together the Jamboard. Okay, so rehabilitation is, people tend to think that it's drug and alcohol. Like if you Google rehabilitation, that's the first thing that comes up is drug and alcohol rehabilitation. I work in the realm publicly funded where it's more cognitive and physical rehabilitation. So rehabilitation can happen across the care continuum. It happens in primary care. It happens in long-term care, home and community care, hospital care, in the emergency room, in the ICU. It is provided after people have an injury, or it could also be provided as part of health promotion and prevention, secondary prevention. So right across the care continuum, and really enables people to achieve their optimal functional, cognitive, and social function, and really works with clients and families together as partners in their care. So we'll go to the next slide, and just very high level, Rehab Care Alliance, we're a provincial organization funded by Ontario Health. And for those that may not be familiar, I'm sure everyone is familiar with Ontario Health, but it's the agency arm of the ministry. So we are publicly funded and work with providers across the province. And similarly, if you go to the next slide, from a rehab network perspective, locally, we are a regional rehab network. We're actually not funded by government, but we're funded by the hospitals and home care programs across the Greater Toronto area, publicly funded, to work on collaborative projects with a focus on rehabilitative care. Okay. Health policy context. So first slide is a disclaimer, and I guess the animations aren't working because the whole thing just came up. So anyway, cut to the chase. So even a well-researched, well-written policy note may not be successful. And so why is that the case? Well, as was mentioned in the opening, I also but volunteer and have an affiliation as an adjunct lecturer at IHPME, which is the Institute for Health Policy Management and Evaluation. And there are entire courses on the topic of why a briefing note may not be successful. So I'm just going to as much as I can, give you an overview of that together with slides that have been based on course materials with permission from 5010. And so, okay, let's see, does it work? No, it doesn't work. Okay. What proportion of the Ontario budget is spent on healthcare? So I'll just ask, does anyone have a guess? And maybe online, can people put it in the chat? Yeah. So wild guess, 30%. So the whole budget.
We got some guesses of 30 coming on.
Okay, good guesses.
We got one guess of 50.
Okay, also good guess. Every guess is a good guess. Every guess is a good guess. Okay. Okay. And in the room?
I'd say over 30. But
Yeah.
Okay.
40.
Okay, excellent. 50.
Yeah.
Okay. All right. The answer is going to be on the next slide. So you can see on the bottom left there, the health sector spending is 40% of our total. And this is the current fiscal year, 24-25. And you can see other things like, post-secondary education, which is very important to this group. Children, community, and social services, very relatively small at 9%. Post-secondary, just under 6%. Education overall 17.5%, separate from post-secondary, and other programs including things like infrastructure, municipal housing, what else was there? Industry, infrastructure. So really, healthcare consumes a significant proportion of our budget. And so the next slide, unfortunately, I couldn't find something more recent than 2019, but essentially it gives you the point, which basically is that, so if you look at that 40%, what makes up the health spending? And so 26% of health spending is on hospitals. So a quarter, just over a quarter is on hospital. And again, this was 2019, so grain of salt. 15% based on physicians charging OHIP, billing OHIP. For the publicly funded care that they provide, and then 13% on prescription drugs. So those are sort of the heavy hitters breakdown of the spending on health. And so if we go to the next slide, we can see, oh, yeah, of course, now it's working. All right, and that one doesn't work. Okay, so anyway, I'll get over it. So healthcare is the single largest area of government activity, and it's not just Canada, but it's across the industrialized world. And so why does that matter? It matters because policy decisions that impact how we're spending healthcare dollars have significant, if not massive, implications for who gets access to care and conversely who doesn't get access to care, who pays the cost of illness. So is it the government, publicly funded government, that pays the cost of illness? Is it third-party insurance companies that pay the cost of illness? Is it out of our own pocket and we pay the cost of illness? Health equity, which is extremely important. Also, the sustainability of our health system, also very important as our population is aging. And then, as we all know, that health is not contained within only health and healthcare. It touches on social determinants of health. And so the more that we contribute or take funds to apply to the healthcare spending, it takes funds, there's only so much in that pie, it takes money away from income supports, housing, education, and others. Just, it always reminds me, I was at a talk, a small discussion group with a former Minister of Health, and she said, when I'm in a meeting with the other an interministerial meeting and other ministers, she said they always look at me like I'm an ATM machine because, if they're going to get money, it's going to have to come out of health in order to be able to go elsewhere. So it's really important that policy decisions need to be taken into that context. Also, recognizing that when we're talking about health, we're not talking about widgets. It's not a production industry. Health and healthcare it's very personal, your health, and the people that provide care are people. Yes, there's a lot of AI. Yes, we've enhanced virtual care, but really when we're talking about the economics of healthcare, we're talking about labor and we're talking about the people that provide care. So when we're thinking about making recommendations or hearing government policy potentially about changes to providing more community-based care and providing less hospital care, well, what does that mean? That means people's jobs, it means people's income and their status. So because of that, health policy decisions are almost always contested politically. Healthcare is very political. And so any new investment is going to result in winners who gets funded and losers who don't get funded. Either they don't get any funding or they get their funding taken away. And so the objective evidence is very important, but it's only one factor to consider, which is also very subjective and political. Okay, before we go to the next slide, I'm gonna preempt because I know I do have the animations, but it's not gonna come up, I have a feeling. So I'm gonna describe it for you. So on the one hand, we've got the objective scientific evidence and picture a straight line to policy, you know? We know that, and I saw in the previous one, breast cancer screening, 40, very successful. You need that to implement good care, good primary care. And so does that always happen? No. And so what happens in the middle? Okay, cue the next slide. And of course it's gonna work. Let's see. You go to the next slide. Yes, see? Okay, all right. So there we go.
The images work, but the point by point.
Oh,
maybe doesn't.
all right. I don't have many more. Okay, so what happens in between when we have the objective scientific evidence and resulting in policy? There's a few bumps in the road, and you can click, and those are called the 3I framework. Was anyone interested? You must be. Okay.
We learned about it.
Did you?
Yeah.
Okay. Perfect. All right, so you guys will have all the answers then. And so the 3I framework really talks about ideas, interests, and institutions as contributing to whether or not policy as intended gets enacted or enacted in a different way or enacted at a different time. Okay, I think this is one of the last animations on the next slide. So let's see if it works. If not, no big deal. Okay, it does work. So just breaking it down. So ideas are really the thoughts about what should be done. What does the policy look like? It's more a value, it's a belief, it's an idea of what should happen, which is different than a fact. A fact is something that is rooted in evidence. The sky is blue. And so the two examples there are, should patients have the right to have their own personal health information and monitor their own access to their own record, or is that something that should be held by health information custodians? The other example there, and we've heard about this recently in the news, is if we think about decriminalization of small amounts of illegal drugs for personal use, Dr. Davila, City of Toronto, saw this as a public health issue and therefore wanted to decriminalize it. We saw the response from the, well, also the federal, but the provincial government in terms of seeing this more as a legal matter and not a public health issue. So it really depends on the lens of the issue that you're looking at to determine how the policy may play out. So the next one is interests. We heard a little bit of that, I think, in the introduction in terms of who are the actors, who are the people that really have an interest in this policy. It could be individuals, it could be associations, groups, etc. You can see the examples listed there. And then the last one is institutions. And this is not buildings. This is the formal or informal, so formal rules, formal laws and regulations and acts, and informal rules and norms and precedents that can happen. Okay, so I have just a very brief example and then we'll move on to the next section, but the National Senior Strategy. It's funny, it's green there, it's blue on mine. Okay, and so if we go to the next slide, so objective fact, we have a growing number of older Canadians who are low income and they do not get the care they need to age in home. Fact, you can support that by data. But in terms of the subjective ideas about what ought to be, the thought could be, well, government should provide the needed care for any and all older adults so that they can age at home and get the care that they need. Another line of thinking is that older adults should be cared for by their family. And from a more individualistic perspective, they need to save for their old age so that they can take care of themselves. Very different lines of thought. And so if you click one more time, you can see that conflicts over facts, you can easily present the data, the evidence to say what is the case. But when there's conflicts over values and beliefs, it's harder to resolve because you can see that different people have a different lens on what the problem is. So if we go into the next slide, you'll see ideas about national seniors care, We know that Medicare does cover medically necessary hospital and physician care. Fact. Governments, what they spend, as we saw in those pie charts, fact, that's data. But in terms of ideas, what Medicare should cover outside of hospitals, they're not required to cover. That's more of an idea in terms of what they should spend their money on. So moving to the next one, interest. So looking at who are the key players, what do they define as their interests? How do they try and influence policy, and what has been their success? So if you think about the next slide, from a national seniors perspective, you'll see that the provinces, what do they want? What are their interests? They want more money from the feds, and they don't want strings attached. Give me money, but don't tell me what I should do with it. The federal government may not tell the provinces what to do, but they can use their funding and reporting metrics as levers. There's not many levers. Private insurance plans, they recognize that there's an older cohort of Canadians, and they will want governments to cover care so that they don't see their own costs increasing. The Canadian Medical Association, speaking on the part of physicians, they want them to play a key role. And consumer advocate groups like Canadian Association of Retired Persons, they want more services and they want them now. And so lastly, institutions, thinking about what capacity the government has to make and implement policy. So with any issue, taking into consideration what's the applicable legislation, what are the, who has jurisdiction. So we know that there's also policies that apply. There's tools as well. So sticks, carrots, and hugs. Sticks, basically, it's more of a punitive way of saying, you know, this is the regulation, you need to function within this, and you'll get penalized if you don't. Carrots, more of the incentive from a federal government perspective, providing funding. And then hugs are more persuasive, collaborative approaches. And then again, from a national seniors perspective, we know that the rules that health is under provincial jurisdiction, and the Canada Health Act doesn't require the coverage for non-medical care outside of hospitals, and that's why you see it varies by province. And then in terms of tools, really the federal government is limited into what they can control in terms of funding and reporting metrics. Okay, hopefully I didn't, that wasn't too much duplication in what we heard at the beginning, but I just want to go over we can go a couple of slides ahead. I want to go over two approaches to briefing notes and then give two examples based on my experience in both. So one of them, this is more, I would almost classify this more as like a memo as opposed to a briefing note. And it's really interesting that the SBAR technique was originally developed by the US military, and it's really meant to be very concise. It was adapted for healthcare use in communication about clinical needs, really when it needs to be on a timely basis, very high level, very succinct. It's more like a memo. Having said that, there are many aspects of an SBAR that are being used in healthcare now to communicate not just healthcare, but different aspects. And this is one example, and I'll speak to it in a moment, that we used in SBAR for a non-sort of health-related condition. But so the situation, concise statement, what's the problem, pertinent background related to what the issue is, your assessment, you know, what you think, what you found, and then what's the recommendation. So it really is very concise. Moving into the next slide is more the policy briefing note that I'll speak to, and that this is the exercise that the example is based on. And so similar to the introduction, it is a short, concise document, synthesizes academic articles and policy papers. And this is very similar, but I think it's so important that it bears repeating. Provides an objective analysis and recommendations about what should be done based on that evidence. It's not meant to be an advocacy paper, an opinion piece. It's really meant to be very purposeful and you've got a specific goal and an audience. And as we heard, healthcare leaders, they don't have time. So it has to be really clearly articulated. The next two slides might be a slightly different. And again, I'd love your comment that it really depends on the purpose, the target audience. So, you know, it just gives you different options for how to construct a briefing note. But in this case, for the 5010 class at IHPME, this is the structure that we use, which is the introduction. So 1 or 2 sentences, you know, really tight, very succinct, clear, what's the topic, the purpose, and who is this for? Then a bit of the background that really is meant to describe the context. So it outlines what is the issue, who's affected, what regulations are touching this issue, which groups care about this, why do they care about it, why is it important to them? And it really should take the reader down a pathway. You don't want to have a background that talks here, and then all of a sudden it's a right turn and you've got an analysis on completely different issues. They should be very well connected and aligned. So if you go to the next slide, the analysis, that's really where you want to spend the bulk of your time in a briefing note. This is the opportunity to really outline the analysis, both the pros and the cons. Because you want to provide that analysis because the reader might say, well, what about this? Or have you thought about the cost of what you're recommending? Or have you thought about, you know, the patient perspective of what you're recommending, or the feasibility of implementing what you're recommending? So laying out the pros and cons will let the reader know you've thought a few steps ahead as to what you're recommending and why it's most feasible to action your recommendations. And it's also helpful to outline the criteria that you're using so that they can understand the lens that you've applied, and then may be able to identify, oh, I don't see equity in this list. That's a key issue. And then landing on your recommendation, and there should really be nothing new introduced here. Like it takes you down the path. And you may want to start with, okay, if I know where my recommendations want to go, you may want to work backwards and reverse engineer, so to speak. Similar to crafting the executive summary. I think the next slide I'm going to skip over because I think you've covered what makes a strong briefing note, and the themes are similar to what you've discussed. And then I'm going to go into the 2 case studies. So I tried to craft this in such a way that it gives you the SBAR, but hopefully I'll give you enough background as well. So the situation was that this was more of an SBAR memo on an example that we had. So Ontario Health had started to publish during the pandemic a system recovery report, and that was being circulated, and it indicated significantly lower than expected bed occupancy rates in rehab and complex continuing care hospitals. And that was a significant concern, because as we all know, in the pandemic, there were significant increases in surgical wait times, and there really was a need to enhance access and flow throughout hospitals. And rehab and complex continuing care, often known as post-acute care, is a key destination for many of the patients that are in acute care who need to go on to a next level of care. And so there was concern that the occupancy rates there were lower than what had been expected. So if we look at the background, my organization, we work very closely with the rehab and the acute care hospitals as well, but also the rehab and complex continuing care hospitals, and there are many in Toronto. And we were working with them to monitor their bed turnover rates, to understand the patients who were waiting for care, understand why they were having issues in admitting patients, and then communicating that back with Ontario, Toronto and Ontario Health Central, so that there could be situational awareness of what was happening during the pandemic recovery. And at the time, Ontario Health Corporate had then started to disseminate the health system recovery reports, and that was based on the daily bed census data. So daily bed census every day, 11 a.m. gets reported to the Ministry of Health data branch, and they were pulling that data, and then had created a bed management dashboard that was being implemented. And so we wanted to identify and undertook an analysis to understand the differences and why there was that discrepancy between what the hospitals were telling us they had and what we were seeing in this daily bed census. And so this actually, the SBAR memo was submitted from us to each of the hospitals leadership, the rehab hospitals leadership, to illustrate to them that we were seeing this difference. And so when we compared the data between the two, we saw that the data that they were submitting to us had a higher occupancy trend. And so really the implication of that difference meant that it was giving the impression that there was lower occupancy than there was available. And that was not good because really hospitals were under a lot of pressure to demonstrate capacity, access, and flow in supporting acute care hospitals that were under a lot of surge. So the recommendation, and it sounds simple on this slide, but it actually took a lot of meetings and discussion, as many things do, was really to make sure they were ensuring consistency both between their clinical teams and their finance teams, each of whom we met with individually across all of the hospitals to illustrate this as an issue in terms of the reporting. It raised awareness of the hospitals and improved, as a result, their data reporting and improved the quality of their data reporting. It illustrated and gave recognition on the part of Ontario Health that there was a data quality issue and that they couldn't just use the data that was being reported to the daily bed census and thinking, oh my goodness, these rehab hospitals, they're slacking off. Like they're not team players. They're not taking our patients. Like what's going on? So there were, we highlighted that and there was an appreciation there. And then we also worked with the regional Ontario Health offices to engage the Ministry of Health. And just recently, a few months ago, after we met with them a few times, got Ontario Health to renew or update another provincial educational session on the daily bed census reporting. So the first one had been done in October 2021, which was whatever pandemic phase that was at the time. So that was very positive. And then going into the second example, we just wanted to set the context here. So there were clinical best practices that were created known as clinical handbooks. And so I participated on one for total joint replacement. And the QBP, or the quality-based procedures, was really at the time a new funding strategy of the Ministry of Health. And so they developed these clinical handbooks to look at what should happen from a best practice perspective, what is the data telling us is happening, and what's the delta, and then how do we use this new funding strategy in order to move quality forward for each of these populations. And so there was a significant push through this initiative to move patients, instead of sending them to inpatient rehab after joint replacement, sending them to outpatient rehab. So we can go to the next slide. And then certainly as part of the quality-based procedure initiative was to improve efficiency and incentivize hospitals to send patients to more outpatient rehabilitation instead of inpatient. And all of the clinical handbooks for a variety of populations highlighted that despite the push to send patients more on an outpatient basis for rehab, that the lack of information on outpatient rehab was a significant gap in provincial information systems. Bundled care, very quickly. Hospitals, are people familiar with bundled care? Okay. Instead of going to hospitals and each getting funded, the government in 2018 for total joint replacement gave an envelope of funding. They priced everything out to say, okay, for total joint replacement, it's going to cost this amount. And with the exception of physician fees that are billed to OHIP, they provided a full envelope of funding to hospitals for total joint replacement to say, okay, you surgical hospital A, we're going to give you this envelope of funding. You're responsible for providing the surgery, providing any rehab needed, whether it's inpatient, outpatient, home care based, over a 90-day period. And so the issue with that, and go to the next slide, is that the recommended pricing for the outpatient component wasn't known because the ministry themselves said, we don't have the information systems, like nobody reports outpatient rehab data. So that wasn't actually priced as part of the bundle. So we developed a briefing note to the Ministry of Health bundled care team to outline recommendations on how to price the outpatient component of the bundle for our capacity. So next slide, yeah. Luna, you can read my mind. Are you a fan? You're like on it. There's a Bryn. Anyway, okay, Luna's you're on it. And so we developed, and there was no data set, so we couldn't. The ministry couldn't pull the data, and so neither could we. But we pulled together across 11 hospitals, rehab experts to look at best practice recommendations and the clinical models of care, as well as the financial models of care, and based our recommendations on that. And we outlined in the analysis on the next slide, the pricing, what it did include, what it didn't include, and really outline all of the assumptions there. And put forth the idea that pricing the outpatient component of the bundle would support successful implementation. And that was important to the ministry because they were rolling this out provincially on a phased approach, first inviting hospitals to participate on a voluntary basis. And then the second year, it was mandatory across all. So there was definitely an interest in understanding how to price the full part of the bundle. Bundle holders and providers, the interest groups, were definitely seeking clarity. So the ministry was doing lots of presentations and mapping out the envelope in the bundle, and there was this big gap. What about that? So there was interest there. And the QBP clinical handbook that was authored by the ministry themselves, the informal institution, cited the lack of information on outpatient rehab data as a significant gap. And so what was the result? That's my happy dance. We were, I feel like sometimes we're like the rehab is like the little engine that could. So it was really exciting that the ministry listened to us, agreed with us, and accepted our proposal. And that's how that aspect of the bundle is now funded based on our recommendation, and really helped highlight the important role of outpatient rehab in developing high quality, efficient care. Okay, so I'm ready for the exercise. Should we take questions or should we do the exercise?
We could do how much we have time. Yeah, okay. So there was one that was dropped in the chat way back. And it was actually during while Maria was presenting, so Maria wants to chime in, she can too. But the question was, when you say to not be too specific on the methodology in the context of briefing or in policy brief, do you mean the methodology used to gather any data included in the policy brief, or the methodology of implementing the proposals?
Do you want to take that? I think it was for you.
I think the main idea, maybe you can add on it, the main idea is this document is building towards a recommendation rather than trying to teach the reader the methodology so that they can replicate the study, which is usually why you want to have as much detail as possible in a scientific paper, but in a policy brief, you might not use that properly. Yeah. I don't know if there's anything else.
Yeah, I mean, if it's going to someone in government or someone within an organization, they just want to know that you've done your due diligence. But again, as you've said, they don't need to replicate it. And if they do, they can go to the published literature for that. Yeah.
There's not any other questions in the chat right now, but we'll have time later to come back to it. So if anyone thinks of questions throughout the rest of the event, you can drop it in the chat, or if you're free.
Okay,
we'll get some later.
Excellent. So for the exercise, I just wanted to remind or recall about the 3I framework. And I put the exercise up front, but I have background because I felt like this was there's a lot of nuance here. So we can go to the next slide. Okay, so I just want to set this so you have it top of mind as we go through the information. So your task, you're a health policy consultant for the Ministry of Health. You've been asked to consider how to best support rural and remote communities in addressing emergency department shortages. So outlining the pros and cons of enhancing access to community paramedicine services to address this issue. And so what we're going to talk about in the Jamboard are what are the views of the public or decision makers that may influence this policy change, and ideas about the causes of the problem and who's responsible, who are the people or groups that have a stake, so who are the interests, and what are the rules, laws, and current practices or health system structures that might either facilitate or present a barrier to this, this policy. And then given the pros and cons, would you recommend enhancing access to community paramedicine programs at this time or another policy recommendation, and why? Okay, so just hold that thought, and I'm going to give you some background and then we'll come back to this. So the next slide, perfect. And so this is happening in the media last year and very recently, but hospital ED closures, particularly in rural locations in the province and remote parts, are becoming more and more frequent. The picture here was from June 2023 in Wingham and District Hospital. And the closures are really reflecting an imbalance, supply and demand. Supply, we talked about earlier, health labor is the supply, so shortage of physicians and nurses in the emergency department, and then demand, which is the patients who are coming to the emergency department and really have nowhere else to go. So an imbalance there. And you can see, we were seeing it just from these clips, not only last summer, but also again in January 2024. And then most recently on May 30th. Like in the January one, you could sort of think, oh, it's, you know, flu season, it's over the winter break. It's, you would expect, and we always see surges in hospital then. But this most recent one on the bottom right is from May 30th last week. So expect more unplanned summer ER closures in rural Ontario, say the experts. So not just a flu-related issue. There was an Office of the Auditor General of Ontario report in December 2023, so just a few months ago, indicating that the issues are physician shortages, nursing shortages, lack of community-based primary care as alternate destinations for people to go to, and then also lack of a province-wide strategy to help hospitals deal with these ED closures, in addition to the shortage of nurses and physicians. And you'll see the article on the bottom here from March 2024. There's also one example. There's a temporary locum program, and that's a program that was started during the pandemic, where the government would provide funding to physicians as an incentive to take on shifts in areas that are more isolated. It's been funded on like a 6-month basis, and then a 6-month basis, and then a 6-month basis since the pandemic. And this report from March 22nd, 2024 indicates that the program was extended for another 6 months until the end of September. So it was due to expire at the end of March, and then, you know, however many days before the end of fiscal, okay, we're going to extend it another 6 months. So that really presents an issue for hospitals because they can't plan based on 6 months and not knowing, and recruit staff on a longer time basis. So they're having to plan based on crisis mode, which puts them at greater vulnerability for ongoing closures. Okay, so one potentially promising approach is to expand the role of paramedics. So there's 2 kinds of paramedics. There's the emergency 911 paramedics. You call, they come and provide whatever life-saving, basic or advanced life support service that's required, and then transport you to a hospital. Community paramedics, this role was initially funded in 2014. And since then, there's been various pilots at the time, and it's funded combination of Ministry of Long-Term Care and Ministry of Health funding for community paramedics. And their roles really, it varies across the province. They're also, some of them are also partially funded by municipal governments as well. And they do amazing work. I work with a few of them from different areas across the province. And they do a variety of things. They'll do in-home wellness checks, remote care monitoring, or they may even refer the patient to other services locally. They're not meant to be long-term service providers, but really play an important role in meeting a gap in a lot of different ways. Okay, so there's a very brief article, and I think Luna, you circulated this article. It's research summary of community paramedicine programs. And even if you haven't read it before, you can just scan it on your phone. It's like a 2-second read. And if you read nothing else, there's 3 bullets at the front that really just give you a nice overview of community paramedicine programs. But essentially at the end also indicates that there's still research required to look at the benefits of community paramedicine programs. So I've given you the punchline there. In terms of the current policy context, a plan for connected and convenient care is the current government policy that's guiding our directions. And really there's the 3 pillars: the right care in the right place, which includes care at home and includes reference to community paramedicine, but also includes reference to reducing surgical wait times, increasing or providing faster access to emergency care. There's also faster access to care that includes, I talk about surgical wait times and emergency care, that also includes building long-term care homes, building more hospital beds, and then also hiring more healthcare workers, and which includes more medical spots in medical schools, as of right rules for practitioners across Canada practicing in this province and others. So very high level. And then there's an integrated capacity and health human resource plan that underpins the policy. And then I didn't put this in your pre-reading, but I've given it to you as the Ontario Health Annual Business Plan. You can see they specifically also cite community paramedicine as a key strategy for improving capacity, access, and flow. And the 3 activities listed in the OH Annual Business Plan include supporting the Ministry of Health and the Ministry of Long-Term Care in development of a provincial policy framework for community paramedicine, advancing integration opportunities for CP programs with health delivery partners, and then continuing to advance development of community paramedicine as part of mobile integrated teams to support care at the community level. And then before we go to the Jamboard, just some overview of 2 more slides on institutions. So we talked a little bit about policy, but the institutions. So the Ambulance Act governs the services provided by paramedics, and the Minister of Health is responsible for the administration of the Act, has a duty and a power to ensure that there's an integrated system of ambulance care along with communications, and then establishes the standards for management, operation, and use, and also compliance with those standards. There's also, and when I first learned about this years ago, wow, that's so interesting. So the Regulated Health Professions Act. So there's 26 health professions in Ontario: doctors, nurses, occupational therapists, physios, chiropractors, etc., that are regulated by their own colleges in the province. And they have the authority to perform certain acts and use specific protected titles, and paramedics are not regulated. It's just amazing. There's so much that they do, and the fact that they're not regulated, that's amazing. But they are overseen by and provided delegation authority through physicians affiliated with local-based hospitals, and in some cases, smaller rural communities need to community paramedicine needs to establish relationships with community health center or other primary care providers in order to have that delegation authority. Okay, and then lastly, community paramedicine, they're not included in the definition of the Ambulance Act, and it's not a core activity under the current legislation that governs paramedic services. And as such, as illustrated in the annual business plan, a policy framework is needed to support development of CP services and ensure the safety of patients. Okay, so we have those two. I think I've given you the rundown, and that's why I wanted to sort of give you sort of what the task was at hand, give you some background to help, and then go into the Jamboard. So Luna, are you able to open that up? Do you have any questions on the task at hand?
So I'll be sharing the link to the actual Jamboard in the chat, so it's easier for folks to also jump to the link. Alternatively, people can scan the QR code or click on the URL, but and then if you click on the next frame, so it takes you to the Jamboard where you can add your APIs.
Okay. All right. So thank you so much for taking the time to put your thoughts down. I know it's not easy. Am I okay? Can you see me?
Yeah, we can.
Okay. I just didn't want to stand in the way of here. Okay. So what are the views of the public or decision makers that influence this policy change? And ideas about causes of the problem and who is responsible. So, view of policymakers, community paramedicine is regulated under a college or other framework, absolutely. Need more healthcare providers for fewer citizens because of large area to provide service. Yeah, that's definitely a challenge in rural and remote areas. So views of the public, wait times and ER closures are restricting access to care. That's a really important one. I'm going to come back to that. Increased number of seniors requiring primary care that is not available in rural and remote areas, leading to increased burden on EDs. Absolutely. And citizens are not centrally located. Few people occupy a larger space. Therefore, it's difficult to provide overall services. Absolutely. Paramedics are one way to bridge the gap and not enough healthcare providers in rural areas. So those are great, great points. I think a few others is, I guess the question, we talked about the ideas being the lens that you put on the problem. So I guess the question is, the belief in this case is that if you think, if you invest in more CP programs, community paramedicine programs, that you're going to have an impact on reducing ED visits and mitigating those ED closures as well. We also know that there's limited funds available, only so much money in that pie. And so if we invest in CP programs, who's going to be the winner? CP programs, who's going to be the loser? Where does the money have to come from? And even with the staffing shortages, understanding what's behind the problem. So we know that there's nursing issues, physician issues, but is it because they can't serve rural and remote areas, or is it because a whole bunch of people have retired due to burnout? And so understanding what's peeling the onion, what the problem really is, will help you to understand what policy action. So you provide the local program on a longer term basis to address people not wanting to practice there. There's also the Ontario Learn and Stay program that the government has funded for medical technologists, nursing, and community paramedicine to provide tuition support and that kind of thing. So it really depends on what the problem is. From an idea perspective, the other thought that I had on this one too is that community paramedicine is not well known by the public. So the public very familiar with physicians, nurses, and I'm sure you've heard and seen examples previously that when the government threatens to close a local hospital, boy, do you ever see them come out at Queen's Park and demonstrate, like, don't touch my hospital. So they see that, it's tangible. To see community paramedicine, which is a relatively new field, provides care in the home. I mean, I'm a huge supporter of it, but from the public's perspective, it may be harder to connect the dots on that one. And then I guess the other thought is, whose problem is it? So if you ask, so the ministry, does the ministry operate hospitals? Who operates hospitals? So hospitals are governed by independent boards. They're independent. It's not like Alberta Health Services where they run and operate, well, until they change like 10,000th time. But in Ontario, we have independent incorporated boards that hospitals are responsible for their operations, for spending their global budget, and deciding if they need to hire nurses, agency nurses at an increased rate, or to close emergency department in order to manage HHR, health human resource issues. So that's the perspective of, again, I'm putting this out there as supposition ministry. The hospitals, they think, well, no, we need help, but this is a massive issue. It's pandemic related, it's across the board, and the ministry has the spending power and the policy power to be able to make changes. And so depending on who you ask, different problem. Okay, so who are the people and the groups that have a stake? For sure, rural population absolutely directly impacts them. The provincial government, for sure. Healthcare providers, paramedics, the patients who can't who can't travel elsewhere, and it may not even be city, but even like the next local hospital down the road. Indigenous people who may live in those areas, and other first responders who work within paramedics in these communities. Yeah, absolutely. And even the other services that need to sort of pick up the extra volume when one emergency room closes as well. Just see if I have anybody else. I guess potentially base hospitals, if there's changes to those services. Ontario Association of Paramedic Chiefs might be more of an association type of voice as well. And as I mentioned earlier, and I think you have it up there, is the public, right? So they will point the finger at who. If their local emergency closes, even though it's the separate board that's responsible, who are they going to point the finger at if they have to close? Whatever. Yeah. Right, because that's where the funding comes from, even though it's an independent board. So, and that negatively impacts the public's perception on the Ministry of Health. Okay, I think the other interest groups I would add to are the physician associations, the Ontario Medical Association, the Canadian Association of Emergency Physicians. I would expect they would like to see more funding directed to physician resources, given the lack of physician staffing, and also to primary care, given that that's seen as a major factor in ER overflowing across not only Ontario, but the country, and also nursing associations as well. I would expect they would like to see more funding for nurses in the emergency department, or even nurse practitioner-led clinics, which is also referenced in the connected care policy document. So providing more care in the community, but funding for nurses either in the community or in the emergency departments. The other groups, I would think, the interest groups, hospital CEOs, and they're represented by the Ontario Hospital Association. So having that voice more at a provincial level to represent voices of hospitals. And I think we have the Ministry of Health there as well. Yeah, provincial government. And there's speculation in the media that the government may call an early election. And so at this time, wanting to keep positive perspectives between the government and the public may influence whether or not this is the right time. Even though it may be the right strategy, it may not be the right time given the current context. Okay, what are the rules, laws, current in health sciences research community? What are the rules, laws, and current practices or health system structures that may constrain or enable the policy? So for sure, I've seen a number of you write down the lack of regulation for paramedics, Regulations will provide province-wide compensation package, which could attract more people in the profession. They're not regulated, may put those at risk, lack of regulatory body, lack of a province-wide strategy for sure, and that was cited in the Auditor General's report. Unclear payment structure, lack of payment from provincial government, sometimes just municipal, and current informal practices of going to the ER for non-emergency creates too much strain on the hospital. Yeah, those are all really good points. The Connected Care Act would be another, I think I would reference there. The focus does align with increasing access to community care medicine services, but it also has a focus on emergency care, home care, expanding primary care team models. So those are sort of competing interests in terms of funding. The Ambulance Act and standards there, as well as I think you've talked about the lack of regulatory guidance and the lack of a policy framework for community care medics in Ontario. Okay, and given the pros and cons, so what does everybody think? Where would we land? So someone says maybe, yes, yes, maybe. I like that one. Encouraging repopulation in rural areas. So overall happiness of aging rural population increases. Access to paramedicine doesn't have to be so high. So I think what I'm hearing in there is maybe a focus on rehabilitative care, which always work. Paramedics would be able to facilitate access to wraparound services. Absolutely. And would depend on the evidence. For example, what is the cost versus the benefit of expanding community care medicine rather than another solution? And then this one would recommend regulating paramedics and expanding services, all the while collecting evidence on costs and benefits, and then avoiding the need to go to more expensive hospital. I don't know if this one is continued there. I think it's like, okay, and avoid hospital stay and reduce quality of life. There's a suggestion to run a pilot program. We are the province of pilot programs. I'm sure you've heard that. On several rural communities, and after a year expand province-wide and show improvement. This one is yes, recommendation, but also coupled with revision of structures outside of paramedics and urgent care that can support aging rural population. Increasing the scope of paramedics could be good policy to reduce strain on hospitals, particularly services that could allow reduced legal risk, and perhaps overall provincial funding needs to be improved to ensure quality for remote communities and health across remote places. Absolutely, I think those are all. The other one that I had noted as well, not a huge, well, it's an important one, but I think you've got the main ones is PHIPA as well, which is the Personal Health Information Protection Act. And the other point was whether paramedic services are positioned to take patients to other destinations other than the ED. So if they need care, can they take them to mental health and addictions facility, for example? And that does require, from an institution's perspective, planning and a formalized approach with other partner agencies as well. Okay. So if we can just, I have one last slide to summarize. Luna, are you okay to go back to the slides? So I hope through that, you know, it's one thing to tell you how to write a briefing note, and I can give you, you know, it has to be well researched, and you have to clear purpose statement, and, you know, write the pros and cons. And I've been an adjunct lecturer in IHPME since 2014. And it takes students a full semester to learn how to write a good briefing note. So just telling you how to do it is not going to cut it. And so within the hour and change we've been together, I knew that just telling you about it wasn't. So I really wanted to use the 3I framework as an illustration to say that you can have all the best evidence in the world, but it's not necessarily going to get you that straight line to the healthcare policy that it intuitively should get you to, because of taking into consideration the factors of the ideas, the interests, and the institutions that really play a key role in influencing how policy gets made and what policy gets created and what policy doesn't get created. And so, you know, the key message here is that scientific evidence is only one and not always the most important factor that drives policy. So I will leave you with that message, and thank you so much for having me, and happy to answer any questions.
Yeah, so there were a couple questions / comments put in the chat in the last couple of minutes, and if anyone else has more, feel free to keep putting them in the chat. We can do a couple more. But back when we were talking about kind of the background of the paramedicine issue, one person put, how do physician's assistants fit into this role? And then said presumably CP care, which I think is community paramedicine care, would be less costly than emergency department care and potential hospital stays, if the issue isn't addressed in a timely manner. I'm not sure if those were connected, but that was one person's comments. So I guess addressing how, like, do physician's assistants fit into this kind of like maybe reducing strain on emergency departments and such.
Yeah, I think that's another great. I had one student in my tutorial who's a physician assistant and also described there's so much opportunity with roles such as that to complement existing care. And there's a number of years ago, it used to be every meeting I went to was talking about ALC, which is alternate level of care. There's people in hospital beds that need to go elsewhere and we don't have the capacity. That's still an issue, but I'm now hearing everywhere I go is health human resource issues are the number one. Like, you can throw as much money, even if we don't have it, throw as much money as you want at a problem. But if we don't have the people to implement, and healthcare is care driven, it's health human resources driven. So we need to look at alternate solutions and different models of care, using community paramedicine, using physician assistants, using nurse practitioners, using rehab professionals and others to look at what those opportunities are. So yeah, absolutely, I would say bring it.
Yeah, and then there was one other question, or I guess suggestion in the chat as a comment on the for the last box of the activity. What they wanted to add was enhancing the role of Indigenous medicine in rural communities to be another possible.
Yes, love that. I had the very good fortune and privilege of being invited to a fly-in community in Northwestern Ontario, and the value and the impact of having people of Indigenous heritage to provide care to those in the community cannot be understated. So I think that's a fabulous suggestion.
And we've got one more question in the chat as well. So this question is, when you create a policy rule, do you tend to make it more beneficial for public hospitals or big hospitals like Sick Kids and UHN rather than if they put private hospitals, but they're clarifying to say small hospitals such as St. Regis, etc.
When you do a policy rule?
Yeah, I mean, maybe when you're kind of trying to write a policy recommendation, perhaps, or come up with a policy.
Yeah, it's interesting. Just as an example, so using this example, again, I think it's Maria, right? So I think Maria's comment at the beginning is really a good one, that it really depends on who the audience is and what the topic is. So that's going to depend. I don't know if I have his comments in my notes, but I did consult with someone that I work with in Toronto Community Paramedics, and he said that he said, actually, I said, you know, I said, I'm having trouble coming up with cons to this policy because it just, to me, means it's such a good idea. And he said, actually, community paramedicine does well in rural areas where the call volume is low. You can use resources that are in the 911 system to do home visits and follow up on action items such as referrals, etc., between 911 calls. And it allows funding and resources to go further as staff and vehicles in the 911 system can be leveraged. So he said it's harder, and he works in Toronto. It's harder in Toronto where they're very busy and there's lots of 911 calls. And so you need dedicated community paramedicine resources to provide that service. But in areas like Thunder Bay or Sudbury, maybe not so much Sudbury, but Thunder Bay and others where there's smaller rural communities. There's more flexibility depending on the lower call volume and how you can apply it. So I guess it depends, like that, the question about policy, it really depends on the context and what you're trying to achieve.
There wasn't in the chat yet, but I had like a little follow-up on the last question, I guess, that I thought of was like, I guess as a broader question in the same vein as this, when you're coming up with policy recommendations or deciding which policies to recommend in a briefing note or a policy briefing, how do you kind of balance prioritizing the interests of, like, for example, larger organizations like big hospitals versus smaller organizations whose concerns might be equally valid, but they don't have as much like political powers?
If I was writing a briefing note, I want to get in the headspace of who's reading it and understand what's driving them and that's why the 3I framework is so helpful, because it really illustrates who are the interest groups that we need to take into account and how loud are those voices going to be, and then how do you counteract that based on the recommendations. Maybe you can, maybe you can't, but at least if you have awareness of the ideas, the institutions, the interests that are going to be influencing the decisions of whoever you're writing the briefing note to, it will help you to be able to counteract that and position your recommendations or your approach within that context, so you go in eyes wide open.
There was, I think, maybe commenting on the conversation that's currently going on, but need to understand the political climate / lens at the time.
Yeah, exactly. And that's further to my earlier comment that maybe this would work in an area where the government is just in and they're just fresh, but if they're, gearing up for an election, we all know that they want to make sure that they can attach their name to say, see, we did this, and it's very visible and readily recognizable. But
yeah, there was one other comment about that conversation that just came up now, which was, I see, so does it mean you will tend to bigger hospitals because they have a bigger voice? Like, I kind of see what they mean, where if larger hospitals or larger organizations have more like kind of influence with politicians, say, and you're trying to communicate to a politician and trying to get into the politician's head, what do they care about? Maybe they care more about the opinions of the larger organization.
Yeah, I see what they mean, but on the other hand, rural and remote issues are a significant issue. And, we saw in the news clippings here that if their hospital ED has to close, that's a huge issue for those local communities. And if it's happening across multiple local communities, there's strength in numbers in those smaller communities. And so I would look at it like from that perspective. Like the big organizations of the world have their issues, but then there's also issues that need to be addressed in rural communities, which I would think are equally important for different reasons.
There's one more question in the chat right now, which is, should you have a briefing note available for when the time is quote hot? I guess for when the issue is really at hand in the public eye.
Yeah, if you can anticipate what that is, that's a great thought for sure. And I have to say that the preparing for this has like even taught me, because I'm now going to go and write my own briefing note back again to try and get more outpatient rehab data. We were successful in getting it as part of our bundled care initiative, but other than total joint replacement, it's not reported publicly outside of hip and knee arthroplasty. But so I'm going to take my own advice and I'm going to write my own briefing note. We'll see where it goes.
Are there any other questions? Give it a second. Oh, just got one in the chat. Interesting question. When you are a health policymaker, is there a rule for you to not own a hospital?
I would think so, yes.
I would expect maybe. I don't know.
Yeah.
I don't know the answer to that.
Yeah.
I've got a question about bundled care, just now, this is just for personal interest. So you mentioned that there was a strategy where they were mandated to take care of the 90 days post-op. So is that kind of like the rehab and physio that people get post-surgery that's affiliated with a hospital, for example, like a Toronto Western Fracture Clinic, you'll get like your hip and knee replaced, and then they organize you to go for physiotherapy, and they have a rehab actually in the same hospital. Is that a part of that 90-day treatment kind of carryover?
Yep.
Yeah, okay, and then, so if we're walking through like a patient's experience, what happens after those 90 days? Let's say that they need a little bit more, where do we go? What's next?
Good question. Really, the bundle holder should be responsible for providing rehabilitation until the rehab goals are complete. But it's not meant to be a long-term. So the evidence says that the majority of patients should be able to heal and return to function within 90 days. But there are there's sort of one-off situations when patients might need a little bit more, or, not every patient needs only home care or only outpatient. Sometimes they need inpatient rehab, and then they also need home care. So the bundle holder is responsible for paying for whatever the patients need, and sometimes they need to pay more, sometimes they will pay less, and it's meant to even out. Whether that is actually the case, I haven't done a formal evaluation of bundle care, so I'm not sure.
Any in-person questions? Feel free to raise your hand. I'll just give it a minute to see if any more come up in the chat. But otherwise, I can do a quick follow-up of your own. Okay, so I want to say a really big thanks to Charissa for coming and sharing all of her expertise with us. And I'm just gonna do a few little outro statements and a little bit of shameless self-promotion for TSPN. So if you guys are interested in science policy and you want to get more involved in TSPN, which is Toronto Science Policy Network, best way to do that is to join our Slack and our mailing list to keep up to date with what we're doing, and any volunteering opportunities or opportunities to join us come up. You can also follow us on social media. Go to the next slide. Also the links to join our mailing list and the Slack are also on our website, so don't worry if that went by too quickly for you. And just a couple of things that are coming up for us. So we're going to be having our TSPN summer social coming soon. We do this at the GSU Pub. So if you want to join us there, it's really just kind of like a casual meetup, and we eat some food and talk about science policy like nerds. And if you want to stay up to date on when that's happening, join our Slack. And next slide. So the next few things that are coming up for us other than the social are going to be the annual general meeting, which is going to happen sometime late July, early August usually. It's going to be a Zoom meeting, and we'll talk about some of the activities that we did this year, maybe some upcoming ideas that we might have for the next year, and talk about some constitutional amendments. And then we'll also have our elections coming up in August. So I would highly recommend, if you guys are interested in science policy, to join the TSPN executive team. You really don't need any experience at all. The only requirements are to be a UofT student who has attended at least 2 TSPN events or meetings. And so if you're here today, even on Zoom, you're already halfway there. If you join us at the social, you're all the way there. So yeah, it's a low barrier to entry, which is great, I think, because we're really here to kind of get people in the door to science policy. And go on, and that's it for us. So thank you all for coming. Thanks, Charissa, again. Let's see what happens.